Well, hello again, Eric Preuss with the Iowa Department of Public Health. I want to welcome you to the IPN Problem Gambling Outpatient Treatment Lead TA call here on February 20th in the great year of 2020, so we can all have much clearer vision on things this year. I see some of you have already started to use the chat feature to announce who you are and on the call. We will have that by registration, but certainly feel free to announce yourselves via the chat to everyone to let everyone know who's on the call today. It is being recorded and we will have it posted. I did post via the chat the PDF that we'll be using today. If we make any changes to it today or I make any notations, we'll get that updated and get a new one out and posted to you. But really want to thank you for being on the call. Also have with me, I think Kevin Gabbert is from Iowa Department of Public Health is also on. I'm seeing whether he has joined as much. I know he was in another meeting. And I'm not sure who else might be on from, or Mary Crawford is on from IDPH as well. So thanks to Mary being on and listening in as well. So we'll go ahead and move on to the next slide here, just as the general welcome. Most of you are pretty familiar with Zoom, but just with a large number of people on the call today, just ask that you keep yourself muted on your end. You can do that by clicking through the microphone on the lower left-hand part of your Zoom window, and to access the chat, there is the chat button over there. And again, most of you are pretty savvy with Zoom, but headset is generally best to reduce background noise. But just remember to keep yourself muted. You're able to ask questions as you're able to through the discussion today. But also ask you to put those questions in chat so that we make sure that we've got those all answered and make that part of the information that is available today. So we all go ahead and go. So here's the agenda that we've got set out for today. We only have an hour, and it would not surprise any of you that there's a lot of information that's going to be coming forth here in a rather quickly, rapid-fire way. So it hopefully won't sound rude or anyway if we try to get through questions quickly or there doesn't feel like to be enough questions, but this is really just a sense to get some pertinent information out to you in light of several discussions that have happened over the last several months, and certainly requests for technical assistance that have come to the department regarding problem gambling treatment. So we'll do some review of some of the data that we have currently, which I shared with some of you that are on the call because you've been in some of the meetings where we've shared that information, provide an update on the DGSPS and the guidance and what that's all about. Talk a little bit about the SUD admission gambling addiction data. Again, that's been referenced on a couple of other calls. I'm going to spend a good amount of time, hopefully, talking about this new service called Community Outreach. We kind of talked about it at the IBHA meeting, the IPN meeting at the IBHA earlier this week, and give you some guidance on that, show you how you can do that and that type of thing, and I'm sure there'll be questions on that. And then also want to just make sure that everyone's aware of the problem gambling treatment resources that are available out on the website, and then, as I mentioned, have time for questions at the end. So that's sort of the map for the next hour. So I want to talk to you a little bit about what are we seeing as far as problem gambling enrollment data since the birth of the IPN about a year ago. So some of you, again, are familiar. You've been on IGTP stakeholder calls with me in the past for the new providers that came on just in January. Some of you have seen this and have used this in some of the presentations, but this graph goes back to January of 2018, where we can see that our monthly census was up around 180 patients or so. If I would go back in time to when I started with gambling here in July of 2018, we were about 250 patients a month was about what our touch was. If you go back a decade before that, it was close to 1,000. So we have seen this precipitous decline. It's just not about the IPN, but it dates back quite a bit of time. But it's taken a very precipitous fall with the advent of and the commencement of the IPN in January of 2019. And you'll see that, and here's the what we saw at the end of the old IGTP RFP as we were transitioning to the IPN to where we were around 50 or 60 patients, and now we've plateaued over the last couple of months right around 35 a month, and that's for all 18 agencies that are involved in the IPN on the problem gambling side. So that's about less than 2 patients per agency across the state right now. So anyway, that's what the data is showing, and that's part of why we're having the call today, to see how we can reverse that. Just a couple other data points just to show you, the other trends that we're seeing. This is just looking at placement screenings over the last 3 fiscal years, just to see the relationship. It's very interesting. We have the same trend the last 2 years of where, we're busy at the beginning of the year and not so busy at the end of the year. Not sure the trend, I haven't done that trending all the way back to 2013 to see if that's the same trend. But again, you'll see for SFY20, even below where we were at the very beginning of SY20, and it'll be interesting to see as we get to where the IPN started in January of last year. We had a bit of a spike, and then it's kind of been in that 10 or 15 range where we were up, in the 40 or 50 range normally per month of patients that were being screened for problem gambling. On the admission side, this is what it looks like. Someone will ask, why is it always spike in January? I'm not sure. It did not spike this January. I don't have the January point on here, but it was 6 again for the month of January, at least for the data that's been submitted so far. So again, it's leveled off. It's not going up. But again, historically, we've been between 30 and 40 admissions, new admissions each month within, from a historical perspective. Some people have asked, well, does Your Life Iowa 1-800-BETS-OFF, how does that look compared? So this is showing, again, some trending, looking back to July of 2018, going through last year, and outside for this decline and spike that happened in August and September of this past year, it's been pretty flat around 40 referrals a month that have been going out to the providers. And again, with the IPN in January of 2019, those referrals are being spread across 18 providers instead of the 10 that existed prior to IPN. Some may ask about the warm handoffs. Those were discontinued in June, July, August, sometime in that frame. I think the last data point I have here is June of 2019. And those, for those who are not familiar with what warm handoffs were, that was one of the requirements that was under the old Iowa Gambling Treatment Program RFP, where counselors were available 24/7, 365 to take a warm transfer from a call from 1-800-BETS-OFF, now Your Life Iowa, to serve Iowans at the time that they've made their call regarding their concerns about their gambling. Couple more data points, just looking at by service area, how this is looking like. And this is a January through January comparison. So there's an overlap of the 2 Januaries, January of 19 being in both of the columns here. The none would be those people that have been served out of, that were actually served out of state, was the residents, and that's why they don't necessarily, they were served within a service area, but they were out of state, so we pulled those out. But you can generally see that from a year-to-year comparison, we've had about a 71% decrease in the number of Iowans that have been served, from about 773 to 225, and then you can sort of see the breakout by the current service area. So this is, obviously in January of 18, we didn't have these service areas, but we took the numbers that we did have in the data system and put those into the new service areas, and this is how it spreads out. The yellow highlighted ones are just indicating those that have been stable or increased a bit over the past year. I think the next one we're going to look at is going to show the admission comparison. And again, this is showing calendar year 2018-19, and then I threw January in there for calendar year 20. The change and change percentage is just looking at calendar year 18 versus calendar year 19. And again, highlighted those that are stable or have saw no increase, and then you can see where the decrease is. So we've had about a 47% decrease in admissions calendar year to calendar year. But if we go back to calendar year 2017, we were over 300 admissions. So it's, again, dropped pretty significantly. So let me just stop there and see if there's any questions on that data. I think it kind of speaks for itself, and one of the reasons why we're having the call today. Any questions so far? Okay, well then we will move on. The next thing that I wanted to talk a little bit about is what are some of the things that we can do to potentially help turn that around. And I want to first give a shout out and a thank you to those programs that, because everyone did a great job of getting in the data that I had requested that was being entered outside or that you were tracking internally at your organizations. And I'll be giving you some feedback. We'll talk more about that later in the call today. But just wanted to give a thumbs up for your response to that. Very helpful information for us. And I said there'll be some stuff that we're going to be going over in these next couple of slides. It's going to provide some clarification, and some of it may be different from what you've heard previously. But feel free to ask questions, either via chat or jump in when you feel like. So looking at a DGSPS and SBIRT, wanted to provide a little bit of guidance on that so that we're all on the same page on how that should be working and the different scenarios in which that can happen. So this is the language actually out of the RFP and out of the integrated provider, the IPN provider manual. So that SBIRT is an integrated evidence-based approach that offers providers the tools to effectively and efficiently screen individuals for risky substance use and problem gambling. Obviously, today we're talking specifically about problem gambling. SBIRT stands for Screening, Brief Intervention, and Referral to Treatment, and refers to the following processes: that there's a screening done that quickly and assesses the use and severity of substance use and or problem gambling, and again, today's focus on the problem gambling. That there would be a brief intervention if warranted by the results of the DGSPS, which would be a brief motivational and awareness raising intervention given to individuals determined to be at risk for problematic substance use and gambling. And then the last part of that is referral to treatment, referrals to specialty care for individuals at high risk for substance use and problem gambling disorder. That just sort of lays the groundwork and the foundation so that we're on the same page. So a couple of other, again, this is also out of the provider manual. A service historically offered as part of the SBIRT process has been brief treatment. Although brief treatment can be a referred service, it is now funded as SBIRT. Previously, that was all sort of under that early intervention umbrella that existed prior to September. And again, we'll talk about this a little bit later, early intervention is now considered an admitted service, both under problem gambling and for substance use disorder. And SBIRT services are to be provided by substance use and problem gambling treatment providers in a variety of locations outside of the treatment center. And examples that we've included include primary care settings, schools, and casinos. So one of the questions you're going to ask is, well, Eric, we're doing DGSPS for our treatment patients, and that's perfectly okay to be doing that. It's a licensure required activity that you do assess every patient for problem gambling, but that's not something that falls under this kind of SBIRT talk, and I'll clarify for a little bit here as we move on. So the DGSPS, or the Disordered Gambling SBIRT Pre-Screen and Screen, some people were wondering, well, how did you get it named? Don't ask, we just threw a bunch of letters together and came up with something. No, it's when we developed it, we had this really, really long name, and DGSPS comes off the tongue, much clues. So, as I said, it may be used in the SUD treatment setting to identify patients whose gambling may be causing problems for themselves, but it's not a billable activity under the IPN. and that may raise some questions to you, but the second part of it, SBIRT may be billed for a positive DGSPS and a brief intervention and referral to treatment if a referral for treatment is provided. So in the context, and this will be some of the feedback coming back from the data reported, perfectly okay that you use the DGSPS on every person that's in SUD treatment. It's a good tool. It shows some great evidence. It will show you some data here of some of the data, the DGSPS data that's been entered into ISMART. But the only time that it becomes a billable activity under the IPN, and whether substance use or under problem gambling, is when, in this case, when we're looking at problem gambling, you're screening for problem gambling, there's a positive screen. At that point in time, there would be a conversation with that individual specific about the scoring, and either a brief intervention and a referral to treatment. And that would be the billable piece when we're talking specifically about screenings that are happening at your SUD treatment facilities. The other piece is that SBIRT activities may not supplant licensed SUD treatment hour requirements that may be in place by licensure for residential services. So as far as tracking and reporting of DGSPS, and my guess is that many of you are doing this, and some of this happens automatically if you're entering them into ISMART, and we'll step to there. But these are the things that we'll be looking for when you're using the DGSPS, and you're billing for your SBIRT activities, that you've got documentation of these things that are happening. So just the number of DGSPSs that you've conducted, the number of those that have had positive screens, the number of brief interventions that were provided, the number of brief intervention and then referral to treatment, and then tangentially with that is then, and then did those people show up for a placement screening for problem gambling? Did they show up then for a problem gambling admission? So this is one of the ways that this looks like in ISMART, and this is just looking at data from January of 19 through January 31st of this year of the programs that have entered DGSPS into ISMART. And again, not required to enter DGSPS into ISMART, but if you're using ISMART, it is a tool that you can use if you've got a client profile all created, and you can stick that in there and then it gets in here. What's very interesting here, and I took the percentages and stuff off of here, but a very, very high correlation that you had 66 that were done over the year that were entered in the system, and we had 40 that ended up having a referral to treatment, and 12. So you had 52 of 66 of them actually turned positive, and you had an additional 7 of those that ended up with giving some initial screening and feedback to. So out of the 66 that were done, there were only 49 or 7 of them. So 59 ended up actually having a positive scoring. So I'm going to stop there real quick and see what questions that individuals have, whether any additional clarification is needed as we talk about the DGSPS and SBIRT.
Hey, Eric, this is Julie Spicer with UCS.
Hey, hi, Julie.
Hi. I had sent you an email, but since you're asking for questions, this is a great time to do it.
Yep.
So we had a clinician who was out at the jail who did 12 screenings in 2 hours. I don't know if, I think maybe one of them came back positive. So as far as like the IPN grant says, we can get reimbursed $35 for a 30-minute unit. Are you saying that we can only be reimbursed for that one positive screening?
Yep. And so, Julie, that's a great question because I didn't cover this, and it's a slide I forgot to put in here as for further clarification, because what we just talked about was SBIRT activities that were happening within your substance use disorder treatment facilities. What you've just described is something that's happening outside of that. So when we go back to this, oops, I went too far. So when we were looking here, SBIRT services are provided to substance use and problem gambling treatment providers in a variety of locations outside of a treatment center. So examples would be primary care settings, schools, casinos. You bring up another of that, hey, we went to the local correctional halfway house. That's a little bit different. And so in the scenario that you've just talked about, if the counselor was there two hours to do 12 screens, then you can build the 2 hours for those 12 screens. You would tabulate that, and then if there was additional expert time for that one positive that you did brief intervention or the screening feedback, or even potential referral to treatment, you can bill that in addition to those 2 hours. Does that help?
Yes, would that be billed under the experts then? And
Yes.
just we
Yes.
would just say
Yep.
4 hour or 4 experts?
So yeah, so so you're right. So you would bill that as, if they were there 2 hours, you would bill that as 4 units of expert. If they spent an additional 10 or 15 minutes, then you would bill that additional unit for that that time as well.
Okay, and correct me if I'm wrong, but on Monday at the directors meeting, I believe you also said that we could include the clinician's travel time.
That would be for community outreach.
Oh, for outreach, you're right.
Yep. Yep. And
Okay.
we'll talk about that shortly.
Okay. Thank you so much.
Yeah, no, great question. Thanks, Julie. Any other questions on DGSPS and expert?
Hi, Eric. It's Allison from Sassy.
Hey, Allison.
Hi. So I have a question. What if you want to use the DGSPS as a screening tool for people who are not currently patients as SUD patients?
So give me the use scenario that you're thinking about.
So just a group of people that you might be doing just they might be, I'm not sure if they're not patients yet, but they might come to your agency and they want information and we're like, ooh, we should screen them before they even become a patient.
I have an example for you, Allison.
Okay.
Yep.
I was thinking of, we do Narcan trainings it's at Sassy, but it's completely separated from Sassy.
Mm-hmm.
And we can do the DGSBS at those points in times. Yes, it's at Sassy, but it's not Sassy patients. They're not admitted.
Yeah, so that would be a scenario similar, that you're doing it to a targeted population that are not patients. So it would be the same as if you were doing it at a correctional facility or at a school or collegiate environment, etc.
Thank you.
Good question.
So is that like the biggest difference that we should look at, patients versus not patients?
Yeah, actually it's more of what's happening. Yeah, yes, that would be the better clarification. So patients, where I was hemming and hawing a little bit, it's patients that are part of your SUD treatment facility, because you may be seeing patients in other settings like mental health facilities, that type of thing. But so that's why I was hemming and hawing, but yes, that would be correct.
Eric, this is Marie with New Opportunities.
Yeah, hi Marie.
Hey Eric. Hey, just a little question, clarification maybe. With the patients versus non-patients, I guess I'm wondering what the rationale would be, because when an individual comes in, and yes, I know we have to screen them, we do the live bet or whatever we may utilize, but most of the time what we've seen is that people aren't engaged necessarily, then they are not maybe as forthcoming.
Correct.
And so I'm wondering, why wouldn't we then go ahead and screen them after they've been engaged in the SUD services for a gambling screening, and then see what those are? I think we're missing a huge potential there.
Yeah, Marie, there's no limit on when you can do the DGSPS, and there's no, and I think you have provided a perfect example of that. It's probably, you could do a DGSPS at the beginning, you could make it part of a group activity, if you're doing education about gambling in a group setting. You could say, hey, we want to revisit this 30 days into treatment. But again, that's part of your just updating your ASAM and those types of things that are going on to say what's the need that's going on with this patient. But should they screen positive, then it falls into that expert, that you could bill it as expert.
Okay, but nothing for me as the individual that's doing the gambling with our services. is being able to do an educational group and then afterwards being able to do a screening with them, and then maybe they test positive, maybe they don't, but there's no reimbursement then for those screenings if I meet with them
Yeah.
as an admitted client.
Yeah, and again,
Wow.
it's probably as part of, again, you can send us that so that we can think more about that, Marie. But again, the part of this is we're sort of new opportunities is new to this grant. So these are all good questions. What used to happen previously was that prevention staff would go into gambling groups and provide, or substance use disorder groups and provide that level of education. And that's no longer permitted under the IPN. So that's sort of a bit of what you're talking about. So there's a part of me in my mind, and why I'm saying send this question to us so that we can kick it around here, is whether there's an application that community outreach could be used to do that type of a piece, where you could use because when we get to talking about community outreach here in a little bit, that's supposed to be a treatment professional, and the question would be, would a gambling treatment professional, so designated at your agency, go into a SUD group, and could we bill that time as community outreach per se, to raise awareness and create referrals, because that's really what the part of what we're going to talk about, community outreach. So there may be a use scenario, Marie, so just send that along to us or put it in the chat so that we make sure that we get good follow-up with you on that.
Okay, that sounds good. And I think I put it in our update that we had to send in probably a month ago or something in regards to that.
Okay.
Because that's a little bit of what we've been doing, is I go in and I'll do an educational group, and then afterwards I may meet with those individuals and give them the screening, and then be able to see, are they positive or not positive, and then obviously a referral from there.
Yeah, no, good feedback, Maria, appreciate it.
Eric, this is Ron. Got another question?
Sure. Hey, Ron.
Hi. So if our outpatient counselors have on their schedule to do a screening, say 3 weeks after admission, to do a gambling screening 3 weeks after admission, and they score positive on that screening, are we able to bill that?
Yes. Yeah. So that would fall into that SBIRT of someone has a positive DGSPS, then that can be billed under the gambling for that brief intervention and or referral to treatment.
So I bill for the IPN for the hour of individual counseling, plus I'd bill IPN for the screening.
Well, you would bill, right. So you can't double dip on it. So you would bill the appropriate amount of time under the SUD portion of the grant for that, and then you would bill the appropriate SBIRT activity.
Okay, and then what if we begin providing gambling treatment and SUD treatment for the same patient? How do I manage the billing on that?
Right. So that's a good question. So as per the IPN provider manual and the RFP, that once that person has been identified and is willing to be and seek and receive services for problem gambling, then the placement screening would need to be done in iSmart under the problem gambling domain. They would then, a recommendation would be made, then they would be admitted, and then you would be able to bill those specific problem gambling treatment activities to the gambling portion of the grant.
So they have to be admitted in both SUD and gambling?
Yes, that is correct. And that's how it's been for a long time. We're going to fix it with IBHRS, but that's how it is. We have another 18 months to bear with it.
All right, thank you.
Yep. Other questions? These are all good. Appreciate it very much. All right. I'm going to make Maria, I want to make sure I make a note of your question so that I look for that. All right, well, let's move on. And we're going to talk about the SUD admission data and gambling addiction data. And this was something we stumbled upon. I shared a bit of this back in December initially, just as throwing darts up on the wall and trying to understand what's going on in systems. And I think at the IPN, meeting that we had at the IBHA back in December. I shared this originally, and this was an update of that information. So for those of you maybe seeing this for the first time, it's really, I'm asking the question, is there a disconnect here somewhere that we need to take a look at, and how people are talking about their gambling when they come in for SUD treatment. So this is data, and I'm showing it by provider and not necessarily good, bad, or indifferent. It's just what the data is to show those individuals who had were admitted for an SUD service, or admitted SUD treatment, I should say. And as part of that SUD admission work and the admission data that was submitted to the state, whether via iSmart or the central data repository, the information that you've collected in your EHR and submitted to the CDR for the field that talked about other addictions. And these are the individuals by provider that reported that a gambling addiction had occurred. And again, this is for calendar year 2019, that there were 329 of these individuals. So you can kind of see by agency where that sort of falls out. And so we'll come back and talk a little bit about that and what we potentially would like you to do with it, or do some investigation with it. But by comparison, during that same time frame, we only had 119 gambling admissions. So there's a sense that we had 329 individuals in our programs during that year that are telling us they had a gambling addiction, and yet we only admitted 119. And so I'm trying to better understand that disconnect, and whether the data is good, is bad, is indifferent. So we're going to see there's a little bit of homework that we're going to have you do for on this to kind of get a sense, not only for us, but also for you, as to, you know, if we're doing the DGSPS and they're not positive and yet they're saying they have a gambling addiction, you know, I'm not sure how all that flows together or not. It's just data at this point. And then,
Eric, this is Becca from House Mercy. Can you tell me again, what is the question that's getting pulled?
Say one more time.
What is the question that
So
you're pulling this data from?
Yeah, so this question is on the SUD admission. It's where the patient is reporting other addictions. And I think there's like 5 or 6 different values, of which one of them is gambling.
Okay, thank you.
Yep, no, good question. Thanks for glad to be able to clarify.
Eric, I have a question too. This is
Sure.
Shirley Schneider.
Yeah, hi Shirley.
Hi. So I'm just wondering if the information is being gathered from the substance abuse screen. So the patient identifies other addictions. Is that where you're finding that?
Right, so this is again data that we're just pulling straight out of the central data repository. So if you're using iSmart, it flows and it's on the screen in iSmart that where there's a slider box and they choose what other addictions for. I don't know how it would be presented in EHRs and how that question is presented.
So if I'm remembering right, that slider box, is that lifetime or is that the past 12 months, the past 30 days?
It's just saying gambling addiction. I don't know that we have any guidance that they're just saying that, hey, I've got a gambling addiction. And so you bring some insight as to, it may have been 12 years ago and I don't need help for it now. So, I mean, that's part of the investigation here, is that we don't know what this means. That's why we're posing it as a disconnect. There may not be any disconnect. It's just trying to get a better understanding of what the data is.
Okay.
And we're not anxious. We're just interested to find out what you are going to find out when we send you some information about who these people are. And then just I threw the January up there. It was 21 versus 6, which is about the same percentage, about 30%. Any other questions about this information?
Eric, are you going to be sending out like the unique patient client numbers?
Yep. Yeah, we'll send that out. I'm hoping I'm going to get it out to you next week. Next week's kind of crazy for me, but I'm going to do it, or I'll have someone get it out to you. So we've got the report built, and it's just a matter of getting the patient level data to you so that you can look them up and do some research and see what you find. Any other questions on this? Okay, watching my time here. So let's talk about community outreach. Again, for programs that were under the old Iowa Gambling Treatment Program, RFP, we've talked about community outreach, and it's been an available service before, but this is something that's now been added and will be part of the RFA that's coming. And we're jumping the gun a little bit with gambling because we really feel this is something that needs to start now with gambling. Part of the pressure here is underutilization of gambling dollars, and we'll talk more about that here in a little bit. So I'm jumping a little bit ahead, but that's some of the rationale is trying to give you as much flexibility as providers to use those dollars that have been allocated to you for gambling treatment to help generate those referrals, generate increased program enrollments, and ultimately help find and help serve those Iowans that could benefit from services, whether it's a family member or whether it's an individual themselves that are struggling with gambling. So this new service, community outreach, contracts are in the process of being amended right now to allow for the use of problem gambling treatment funds for community outreach. This is some of the language that you'll see in the RFA. So this is language that's out of the draft RFA right now. Contractors may conduct, support, and participate in collaboration and community outreach activities that establish the contractor as a primary treatment resource for substance use and problem gambling in the service area and also statewide. I just want to do a little bit of an aside there because this question has come up from different service providers, is that yes, each of you have a service area, but you're also serving statewide. So there's been examples in the past where we've done some telehealth across the state because we have some providers that specialize in Spanish speaking and have Spanish speaking counselors. And so we've been able to utilize Zoom and some other telehealth situations to link Iowans to caregivers that can provide that service. Some of you have contiguous counties, and based on where, service areas where they're contiguous, that it may be easier for a provider or an Iowan to go to a provider in a contiguous county because it's closer to them. So there is no prohibition as to which provider they must seek services from because they're supposed to seek the provider of their choice. So that was a little bit of the statewide piece. But what is the scenario in which community outreach? A couple of examples here. The presentations that alludes a little bit to the question that Marie asked earlier. Going to meetings, county board of supervisors, other community coalition meetings, lawyer groups, CPA groups, et cetera, and just this other general referral network building. Because one of the dilemmas that you faced as providers is that under network support services, you have these dollars and specific activities that you're supposed to do, but we were never able to put any on, I should say never able to, but there were not gambling dollars that were tied to those network support services. And certainly network support services are meant to be encompassing of all the services that you're offering, and using those network services to build both on the gambling and the SUD side of things. By pulling community outreach out of network support, it's now giving you the ability here on the gambling side, starting today, to be able to start doing this, and foreshadowing that option is also going to be available on the SUD side come July 1 if the RFA ends up being everything that it's going to be as it currently is drafted. So that's giving a brief introduction, understanding of that, and how that is going to be entered, communicated, documented is going to be through the Gambling Education Services log, which I'm going to show you a little bit about that here in a second, and where it is and how you can find it, and a couple of things that we'll need for you to be able to grant access to it. But this Gambling Education Services log, for those that are new, was the old Prevention Services Education Services log. This is where we used to log all of the prevention education services, and now there's a whole new prevention domain within iSmart in which all of both the gambling and the SUD prevention services are now logged. So this has not been used since January of 2019. So we're going to turn this back on, and we'll show you how that is to happen, and we're going to talk to you a little bit about how you're going to log this activity for us and then bill for it. So community outreach in iSmart, how to find where this exists within iSmart. It's going to be under this gambling area. So most of you will have the gambling domain already turned on in iSmart. And then you're going to see this thing called education service that exists under gambling. And that is where you will find this. But one of the first things that we need to do, so one of your homework assignments are for those staff that will be doing, whether it's the staff that you're assigning that are going to go do the service or your data entry staff, whoever that's going to be, but the people that are going to enter this information, this community outreach services into iSmart, you just need to send a email to the SAPG data at idph.iowa.gov with the name of the staff and their email address so that we can make sure we match it up to their iSmart user. And if they don't have an iSmart user account, then we can set it up based on that as well. And then we also have to make sure that they have access to the gambling domain to be able to see those pieces. So it's a pretty simple process. Most of you are pretty familiar with iSmart and how it works. This is what the Gambling Education Services log looks like when you first log in and you click on it. Oops, not sure. Whoops, going forward and not clicking on things I shouldn't be clicking on. So going through here, you're going to click on gambling, you're going to click on education service, and some of you know this about iSmart. If you want to see the services that are in there, when you first log in, it'll be blank. You click go, then you'll see the services that are in there. So for providers who have used this community, have used the education services log before, you're going to see all your previous services are going to be in there. And I'll show you a couple of ways that you can do to filter that. But if you click go, you're going to see those services. There's also a way that you can use the filters at the top to help, and you'll see this when we talk about what's the education service type, so you can filter only to see those services when you click go. There's also an ability to use a date range, and I give a little tip on that here in a little bit. But simply, and then the other thing, there's an export link. So if that you wanted to export what you see on your screen, you have the ability to click on that little export, and it'll download it as a CSV file that you can open up and use in Excel. But basically, to create that community outreach service, you're going to click on add an education service, and you're going to click complete the education service profile and then click finish, and actually show that on our next screen here. So this is what all of that it looks like. Pretty simple screen. It's the only screen that you see on the Gambling Education Services profile in the log. It's going to give you the agency. You're going to see most of them are hard yellow, and participants is not, but it is required to be reported. So you're going to put the date of the service that it happened, the facility in which you're going to be billing this under. And again, some of you just have a gambling facility, and that's fine. It's the location is what the facility is not so important to us. It's a required field. It's going to list the person that provided the service. And again, if you don't have all your counselors that are going to be providing, or the staff that are going to be providing the service in iSmart, then you'll have to load them, add them in as an, put their name in the system. They don't necessarily need to have a user account, but that's how they end up showing up in the drop-down box. You'll select the county and service of which the service is happening. You will have an option to serve right now just to select gambling as the strategy type. Starting July 1, substance use will also be available in that screen. And then you're going to talk about the location of where the community outreach happened. The education service type only has one, and it's outreach, but you'll have to select it. We can't default it to outreach. Then important, this number of participants is not a required field, but it is a field that we need to have you make sure that you fill out. And when we show you the report that you'll use for your monthly claim, there'll be an error on there if this is blank. You'll select your population and then duration. This is a good example of this would be an error because it defaults to 15 minutes. The system defaults it to 15, and you'll need to make sure that it's in a duration of 30, 60, 90, etc. Because that's the way the IPN units are set up. And then it'll automatically default it in hours. And then you'll put your comment in here. I quickly had updated this, and I forgot to put a sample note in here. But simply what we're asking there for is a description of the activity, the outcome of the activity, and if there's any plan that comes out of the activity itself as far as next steps. just trying to keep it really, really simple. So let me just stop there and see what questions that we have before I go on to SSRS and monitoring and that type of stuff.
Hi, Eric. This is Crystal. What is the reimbursable rate for these services?
Yeah, good. So it's going to be $65 a unit. So it's the same as individual counseling. And you'll actually see that on the next page. Good question. And you'll see that also on your amendment when it comes out, that that's listed very specific on the amendment, that it's adding community outreach as a billable service under gambling treatment in the gambling treatment budget in that unit rate table. Other questions about community outreach so far? I know there was a pretty good applause for this on Monday when we talked at the IPN meeting. So I'm hoping this is the same feeling is happening here. So I'll move on. Feel free to ask questions as we go through them, monitoring chat as well. So here's the monitoring and reporting of claims. So there's certainly the education services export option that I mentioned that can be used, and there's filters that can be used to see a specific month. For example, in that date field that I had shown on the previous screen here, you can put, like today's, January 1, 2020, January 31st, 2020, using dates, of course, which is what we're showing here. So here's that example of 01/01/2020, 01/31/2020. Click go, and then you'll see in there, in that log file, in the chart that's below, the table below, just those records that are in that field. And the same way you'll be able to do that by the strategy, gambling or substance use disorder, when the substance use is put in there. And as I said, you can download in CSV technically, but able to be used in Excel. There's also an SSR report that I'll show you on the next screen that is now live in the folder, and I think I have the link on the next page here. And that report is called the IPN Community Outreach Detail. So if you look in the IPN Problem Gambling Treatment Reports iSmart folder in SSRS, you will now see that this report exists. And you'll be able to use that to see the detail and any potential errors. And there's 2 errors. There's going to be this one, and I need to update because I forgot to put the second one on here, is then the participant. If the participant value is blank, then you'll get an error as well, and you'll just need to correct that. I just want to make a note about that so that I don't forget to add that. And then the other thing, the report, and you'll see this when we go to the next step, is that it will tell you the total amount for the month and what the claim amount is for that month. So this is sort of what it looks like when you log into SSRS, and you go into the provider reports folder, and then the IPN Problem Gambling Treatment Reports for iSmart. There is now this new report that I've highlighted there that's called the IPN Community Outreach Detail. And this is what it looks like. So that's the view. You'll see at the top, it'll tell you the total amount of units and how much you are to then add to your claim for this. And so just a quick aside on the claim spreadsheet that you'll be doing, there will not be a spot on your claim spreadsheet to add this. So you're going to have your problem gambling treatment amount that's on your spreadsheet. You are then going to add this amount to that spreadsheet amount, and that's what you'll put in to Iowa Grants when you add it. And then you'll be uploading this each month for the work that you do each month. And it'll actually have a date range up here instead of report month and year here. Any questions on that?
Eric, this is Allison again. Sorry. This is the first that I'm hearing of this, and I guess I'm just confused because this is how we used to do things a year or 2 ago. And so this is outside of prevention now.
It has nothing to do with prevention.
Okay, so now
This has nothing to do with prevention. This is completely outside of prevention. This should not be a prevention activity.
Okay.
So I'm glad you brought that up, because Julie Hibben would be making sure that I made that very, very, very clear. This is expected activity of treatment counselors, of those individuals identified by the agencies to provide this activity. So hypothetically, if you have a prevention person that you thought would be very, very good at this, they could provide it, but then you would have to make sure that if they're funded 100% under the prevention, they could no longer be funded 100% under prevention.
Gotcha.
If that makes sense. So I actually got a question from Mary Crawford about who would actually be sending the request for access to the log, and we would ask that supervisors send that request in, and the staff that they would like access to the education log. That just clears up the confusion, because if we get it just from a staff person and not a supervisor, then technically we can't set up an account or make changes. That has to come from a supervisor. So Mary, thank you much for that. And then Lynn was asking a question as far as community outreach sessions. This eligibility is anybody. There is no eligibility requirements. This is any Iowan in the state. A community outreach service. There's not any organization that is exempt from receiving a community outreach service. This is where you get to do all your brainstorming and thinking caps on about, and certainly I listed off some of those groupings before, the local CPAs, your correctional centers, your attorneys, your credit bureaus, the people who do financial counseling. There's just, primary care, hospitals, emergency rooms. There's all kinds of different places that this can happen. Senior centers, collegiate environments, school environments. So it's really a chance for you. Casinos. I don't want to underscore the role of casinos, is that that most likely is going to be one of your number one referral sources, but it's also not to rule out working with Iowa lottery vendors and providing education to your local Iowa lottery vendors on, how they potentially could easily refer someone who they thought that they could slip a business card in with a ticket or something as they were purchasing a ticket if they thought there might be a concern there, very indiscreetly. Other questions? I hope you're excited about this. I'm excited about this. I'm hoping you guys will take 100% advantage of this, because my challenge to each and every one of you as we move on here is that I don't want to take any more money away. I really hate doing that, because then I have to figure out how to spend it. And we're going to talk a little bit about what we've done and what's in process. But any other questions about community outreach? I know that was a lot of information real quick. I think it's pretty simple. But any
Does
other
it have
questions?
to be face-to-face, or can it be emails?
That's a good question. I'd really like it to be face-to-face, if we can. I mean, certainly there can be emails, correspondence to set things up. And this goes back to, thank you for also bringing that up. So I think Julie was asking about travel time. Travel time may be included in this, but you make sure you document that in the documentation. Then I will make sure that I add that to the slide.
Eric, can you clarify, when does this start?
Today. Starts today. You don't have the amendment yet, but it starts today. So
we can start billing today?
So yes, you can start putting it in the system today. You can start, if you've got access to it, if you wanted to go out and do it tonight because you're so happy about this, you can go do it tonight and bill it. And when you get ready to bill your February claim, you'll be able to add it to your February claim. I'm hoping we'd have the amendments out by then, but you have my permission to go forth and use it today. All right, any other questions? I'm watching our time. I got a few slides to go through real quickly. PG treatment resources. Again, most of you know this. You went through some of the trainings that we did about a year ago when everyone was just new into this, but I just want to highlight choices again. It's out there. We're in the process of doing a reprinting. Some of you have done a great job with this. There's a couple of links in the PDF, and I'll make sure that I send this out or before we log off, I'll put it on, just make sure that, because I know people have joined since I shared this, so I'll share it again. In fact, I might as well just do that right now while I'm thinking about it. And there it is, just so that everyone who's on now can see it. All right, so I just shared that. But here is a click to be able to download it. You can also order them. It's in a booklet form, and that we can provide free of charge, and they come in units of 25, and you can order those by sending in that order form. Then certainly the idph.iowa.gov IGTP treatment, if you've not visited that site, and it has a bunch of resources historically that go back in time. It has clinician resources, financial tool. It has information about the data entry, and there's a training that we did back in December of 2018 that we'll probably do an update at some point in time. I don't have it scheduled, but that is still very current and applicable for new staff about how to enter problem gambling treatment information into iSmart. The screening tool access is how to download the tool is there as well. And again, as I mentioned, it is accessible in iSmart. There's workbooks, activities, and there's also a link for Spanish tools for Spanish. For those of you who have that need, those are kudos to Nick Foss and the work that he's done to get us access to those tools. But again, to use them, you need to know Spanish. They're not much help for me because I know about 4 words in Spanish. So know that those are all out there. Please use them and know that those resources are out there. Another to go on, it's also important just as a reminder about eligibility. I saw this in some of the plans that came back, and I just really wanted to clarify this again from a problem gambling treatment perspective. There should never be any reason a patient is denied service. Never. Unless you can think of some example. There should never be a reason that a patient is denied services because of what our eligibility criteria that were changed in last March. That basically says the burden of the gambling-related debt reduces the patient income to, at, or below 200% of the federal poverty level. And this is the important part of it, is that the patient was without other financial resources to pay for the problem gambling treatment services, regardless of income, regardless. So basically it comes down to that no patient should be denied services due to any financial concerns. So next steps, try to wrap this up pretty quickly and see if there's any final questions to stay. We're about 2 minutes left here. So Katie and myself have reviewed and we'll be returning the submitted utilization plans that you've sent. Thank you so much for that. That was back in December. And then I'll be sending some clarification requests on the data that was submitted and potential changes in claims and what you've billed and that type of thing. That'll all be coming out hopefully within the next week. There's contract amendments that are coming. We're reducing the underutilized amount out of all contracts from July to December of about $260,000 for those programs that were at 100% utilization as of December or very close to that. There are no cuts. So those, so it's not like everybody's going to get a cut, but most of you know who you are that have been struggling to get and utilize those dollars. So the reductions were only there. We are redirecting those dollars to a potential statewide media campaign that's going to run from March to June. We're in the initial discussions of what that's going to look like. We're being very, very intentional that they'll be allowed for local tagging. So you'll be getting contact from all 18 providers. We'll be getting contacted from ZLR for the billboards that will be in your service areas, that we'll be tagging them with your agency logo. If we're using, I think we're going to be using some radio spots, and it'll be the same thing, that we'll be able to tag your agency name into those commercials that are running within your service area. I know that sometimes there's overlap, so we'll just have to deal with that because the way is where the stations are, and they may have overlap. So, but we'll deal with that as we get that. And there'll be more information coming. And the other thing that just came about today, we've had a couple of programs that have requested TA, and there'll be more information that we're going to have problem gambling treatment, technical assistance, regional meetings. Don't know yet the scope and what that's going to look like, but that's probably going to happen in the April through June timeframe. And so if there's of those of you who would be willing to potentially host or assist with a regional training in your area, please send me an email. I'd be happy to talk with you about that. So here's your homework. And this is sort of foreshadowing. We're going to have a follow-up call on March 27th. It's the next, we'll do it a little bit longer. It'll be a 90-minute call on the 27th of March. But here's your homework that I'd like to have you participate in and then report back to us on March 27th. And it's, again, just a month, so it's not a whole lot of time to work on some of these things. But there's a level of urgency here. We have to turn this. Sorry. The emotion that's coming from me is that there are Iowans that are not being served and that are out there not knowing what to do. And we're there to help, and we need to help find them and help provide that environment that can help them navigate that recovery path for themselves. And we're preaching to the choir on that. You're all on the same page with that, and appreciate that. So the three things that I'm going to ask for is I'm going to send you out next week to have you do a little bit of investigation on that gambling addiction and that we talked a little bit earlier in the other addictions. The increased program enrollment piece, just track for this next month, how many DGS you did, how many positive, how many were referred, how many were admitted, report back on the 27th, how'd that go? And again, that can be within your agency, outside, wherever you're making that happen as part of the community outreach, or you're doing that as part of your ESPERT activity. And so that's one of those things, just as a point of clarification. So you can go, and I think back to Marie, where you were talking about, you can go out and do a community or outreach activity, and you can make DGS as part of that. And so you could actually build part of that, DGS, PS, and handing it out and that type all under that community outreach, and then you would build the ESPERT time for any of those that were positive. So that's another way that you can be thinking about that. And then the other part is community outreach. I've given you permission, so I'm curious to hear about what you're thinking about doing, what you've done so far in the first month, and sort of provide a summary for us on the 27th. So my hope, most of what we're going to do in March 27th is you shouting out your agencies and what's working and what's not, and learning from each other. So I think with that, I had a couple other things. Ensure all problem gambling treatment data is entered into iSmart. So please understand that'll be some of the feedback that I'll be giving from the data that you've reported that if you've got current fiscal year data, and it will only be looking at July to current, that has not been entered into iSmart, we're going to ask you to make sure you get it in iSmart. That may mean adjustment on the SUD side if that's where it ended up funded, but if there's questions on that, we can talk about that individually. And here's my challenge for you. You need to spend 100% of what you got left in your contract after we do that amendment. That's my charge to you. And some of you will say, well, what if we run out of money? And I said, don't worry about it. We'll cover you. That's our guarantee. I guess within reason, unless, because hopefully none of you are going to do like $1 million worth of business or something like that. But Deanne has pretty much given assurance that if you're community outreach and expend all those dollars and you see an uptick, you're running out of dollars to fund the treatment, then that's what you're going to be reaching out to us and letting us know, and then we'll figure out what that amount needs to be. And then I talked to you about the report back call is next March 27th from 3 to 4:30. That invite will be coming momentarily, probably in the next week or so, but you can put that as a hold on time. So we're about 5 minutes over. I'm sorry, that was a lot of information to go over in an hour. I probably should have scheduled it a little bit longer, so I apologize for that. Are there any other questions that come to as where we're at now and ending that you'd like to have addressed right now? All right, with that, I'm going to say thank you for being on the call. We had like 35 people at the peak. That was so very good to have all of you on. My contact information is on this. Hopefully you've downloaded the slide presentation. I got a couple of updates that I need to make to the slides, and I'll make sure that I get that out to everyone within the next week or so. and we'll go from there. So thank you, everyone. Appreciate the work that you're doing, and look forward to talking to you again soon. Also feel free to reach out if you've got any questions, and I'll be happy to do that. So thanks, everyone. Have a good rest of your day. Enjoy your upcoming weekend.